undergraduate program to PhD. And we are very proud to be the first higher education in Thailand to receive the award called
undergraduate program to PhD.
The award is called Thailand Quality Class People, and we will receive the award from the Prime Minister of Thailand next week.
Congratulations.
Oh, thank you. Here's the outline of my talk. So I'm going to talk about breastfeeding effects on oral health, including dental caries and malocclusion. I will talk about the evidence from clinical and epidemiologic studies, and a little bit of the possible mechanisms of the association. And lastly, I will talk about recommendations for patients and policy. And you can stop me at any time with question. Breastfeeding is the standard form of infant feeding. And so several organizations recommend immediate initiation of breastfeeding within an hour of birth. Exclusive breastfeeding is also recommended for up to 6 months of age, and continue complementary breastfeeding after up to 2 years and beyond. Breastfeeding should be on demand as often as needed, day and night. So for dentists like us, when we see on-demand breastfeeding, we are kind of worried whether it could increase the risk for dental caries or not. Breastfeeding and human breast milk provide several benefits to both infants and mothers. It is considered the best source of nutrients. It could reduce infectious morbidity and mortality in infants. For mothers, breastfeeding could improve spacing, reduce risk of breast and ovarian cancers, as well as type 2 diabetes. It also promotes strong bonding between mothers and children. Breastfeeding is thought to be able to help achieve sustainable development goals. Several goals that it could help, starting from no poverty, because it could break the cycles of poverty when mothers use breast milk rather than buying formula milk. Also, promote zero hunger for the goal number 2. And number 3, good health and well-being. For number 4, quality education, because breastfeeding is found to increase the IQ of the child. Also, it could promote number 8. Goal number 8 is decent work and economic growth, as well as reduce economic inequalities for goal number 10. As far as oral health is concerned, there are 2 conditions related to breastfeeding. For dental caries, actually dental carie is the only negative outcome that is found to be associated with breastfeeding beyond the age of 12 months. In the famous Lancet special issue on breastfeeding in 2016, this issue related breastfeeding with several general health, and all of them show the good benefit of breastfeeding. So only dental caries in primary dentition is found to be the negative outcome. And for malocclusion, breastfeeding is found to be preventive. It could prevent malocclusion potentially by mechanical feeding action. Breastfeeding and early childhood caries is a subject of debate for many years. in the early studies, most of the early studies are cross-sectional studies and prone to bias and confounding, and the data are quite limited and inconsistent findings. Most of the study conducted could not separate the effects of bottle feeding and breastfeeding, and so the results are mixing. As for the biological mechanism, human milk presents more cariogenic property than cow's milk and contains more carbohydrates but less calcium and phosphorus and protein. So it's actually bad for dental caries. On the other hand, human milk has lactobacilli, which could inhibit the growth of selected streptococci. Protein of human milk might also protect it against S mutant by binding to pellicle-coated tooth enamel. So you can see that by mechanisms, it could be both ways. Breastfeeding could increase the risk as well as reduce the risk for early childhood caries. When we talk about the evidence, we look at the systematic review and meta-analysis, and the highest level of evidence would be from randomized controlled trial. But for the topic of breastfeeding, we cannot actually do a randomized controlled trial comparing breastfeeding to non-breastfeeding group. Like we cannot assign people to non-breastfeeding as a control. And so the highest evidence that we could get for the effects of breastfeeding and dental caries could be from cohort study. But the number of cohort study is not so many. But right now, we have enough evidence. Since 2015, there's a publication which is a systematic review and meta-analysis, which confirm the effects of breastfeeding and risk of dental caries. In this analysis, it concludes that children exposed to longer versus shorter version of breastfeeding up to 12 months had a reduced risk of caries. So this paper actually show the protective effects of breastfeeding up to 12 months. But if the children continue breastfeeding beyond 12 months of age, he or she would have an increased risk of dental caries. However, as I mentioned, the previous studies are prone to bias and lack of or have limited control on confounding. So the effects of prolonged breastfeeding could be due to unmeasured confounder, such as nocturnal feeding, dietary sugars, and oral hygiene practices. And the conclusion of this systematic review is that breastfeeding in infancy may protect against dental caries. Our group in Khon Kaen also conduct and publish a study on breastfeeding duration and childhood caries, and this is in 2016. We conducted our study among about 800 participants who enrolled in a birth cohort study of Thai children in a subgroup of participants in our region in Khon Kaen, Thailand. This is a birth cohort study where the children will follow when they just at birth, and then follow until the children were 3 to 4 years old, that we measure dental caries on them. Breastfeeding and confounding information were collected and updated at 3, 6, 12, 18, 24, and 36 months of age. So we could update breastfeeding information for accuracy of breastfeeding duration. In this study, we classified breastfeeding into 2 types, full breastfeeding and any breastfeeding. Full breastfeeding is defined as receiving human breast milk without formula milk, and any breastfeeding defined as receiving human breast milk with or without formula milk. So the first one, full breastfeeding, is breastfeeding alone, and any breastfeeding is a mix between human breast milk and formula milk. And this definition is used by pediatrists for the study of breastfeeding. Our results show several interesting findings. Right here, we look at the effects of full breastfeeding duration on dental caries. And we compare the duration from less than 6 months as the reference group to those duration between 6 to 11 months and more than 12 months. If you look at the results right here, which is the relative risk comparing, which show the association of breastfeeding with dental caries. The relative risk of 1, meaning no association. If the relative risk is less than 1, meaning breastfeeding is protective. And from here, when we compare 6 to 11 months to less than 6 months, we saw the association, a protective effects of full breastfeeding on dental caries. If we look at more than 12 months, the effects is also protective, but then it's not significant here. On the other hand, if we look at any breastfeeding, so now it's breastfeeding plus formula milk, the effects when we compare prolonged breastfeeding with breastfeeding less than 6 months, the association, the relative risk is higher than 1, meaning that breastfeeding is increased risk of dental caries, but then the results is not significant. So what we found showed the different effects of full breastfeeding and any breastfeeding. So full breastfeeding alone protect against caries, but then when it's plus formula milk, it could increase the risk. Later on, last year, we also have another study on breastfeeding duration and dental caries. And this is done by my PhD student, Dr. Sirima Sitang Surikun. She presented this paper at the Asian Academy of Preventive Dentistry in Korea and won the AAPD Lion Award. So in this study, this is also a prospective cohort study conducted in Khon Kaen, Thailand. Sirima followed the children from 12 months old up until 36 months. And she interviewed the main caregivers of the children to determine breastfeeding duration and collect other information. She also do dental caries examination when the children were 36 months. So she compared the effects of breastfeeding duration to dental caries at 3 years old. In this study, we also classify breastfeeding as full breastfeeding and any breastfeeding to separate the effects of breastfeeding and formula milk. Here is the results from Sirima studies. These graphs show caries prevalence, comparing breastfeeding duration from less than 6 months to 6 to 11 months, then 12 to 17 months, and prolonged more than 18 months. And you can see that this is the green graph is human breast milk, which shows that caries prevalence reduced by the duration of breastfeeding. So if the breastfeeding increase, then caries prevalence reduce. And the result is linear. This shows the dose-response relationship. When we look at any breastfeeding, the pattern look different, and it turned out as U-shaped. So people in the extreme side, those who were breastfed less than 6 months, and those with prolonged breastfeeding have the highest risk for dental caries. So they have the highest prevalence. And the results is actually very similar to another study in Australia by Dr. Lockdow group. In the study, they look at the association between breastfeeding duration and dental caries in the area with fluoridated water in the green bars and non-fluoridated water in the gray bar. The first graph showing the prevalence and the graph on the right show the severity of dental caries. And the two graphs are actually look similar. For fluoridated water, the association between dental caries and breastfeeding is not very, it's hard to tell. It's show that the babies who have sustained breastfeeding, who have breastfeeding a long time, have the higher prevalence for dental caries. But for the non-fluoridated water, the graph look like U-shape. This is very similar to our finding that those in the extreme would have more prevalence for dental caries. The severity of dental caries is also the same, U-shape for non-fluoridated waters. And this study is the first study to show the effect modification, to show that fluoridation could affect the association between breastfeeding duration and dental caries. Our study in Khon Kaen, we are in non-fluoridated area. We don't have fluoride in water. And the result is very similar to Dr. Do's study. And when we look at the association between breastfeeding and dental caries with relative risk, these show the relative risk for full breastfeeding. The relative risk of 1 is meaning no association. And if relative risk less than 1, meaning the result is protective. So right here, the slide shows that full breastfeeding is protective against dental caries. When we look at any breastfeeding, so we can see that babies with prolonged breastfeeding, any breastfeeding more than 18 months, have significantly higher risk for dental caries. So those with prolonged breastfeeding more than 18 months have 1.7 times higher risk than babies who have any breastfeeding less than 6 months. So the results come out as opposites for any breastfeeding and full breastfeeding. How could we explain this? Human breast milk contain several glycoproteins which could adhere with hydroxyapatite, and then it could inhibit the adhesion of strep mutants to the tooth. Human breast milks also have a buffering capacity, which could limit dental caries or remineralization and promote remineralization. And thus, it could reduce carie risk. On the other hand, any breastfeeding is a combination of human breast milk and sugar and formula milk, which is likely contain sugar, so it could promote carie risk. Also, there are evidence that caries protective elements in human breast milk could decline over time. So when the breastfeeding duration is prolonged, the protective effects of human breast milk decline. Our study has a cohort design. It's a prospective cohort study. We follow the children over time and we update the information on breastfeeding so we could reduce recall bias from asking the mothers when they stop breastfeeding. Also, we have a very high retention rate. There are 86% of the children remain in the study, so it is unlikely to have selection bias. Also, we control for several confounding factors, and we define breastfeeding duration according to the different time intervals. And also we define them as full and breastfeeding, full and any breastfeeding separately. So we could observe the effect as U-shaped association. Several previous studies used the binary exposure. They classify breastfeeding duration as more than 6 months or not, or more than 12 months or not, or more than 18 months or not, and so on. So they cannot see the effect of different section of breastfeeding and cannot see the U-shaped association. So when they examine the effects, it could come out as no association between breastfeeding and dental caries because it makes up everything else by lumping together different duration of breastfeeding. Limitation of our study is that no children have exclusive breastfeeding after 6 months because the area of the study is in the urban area of Khon Kaen. And so most mothers, they work, they are employed, and so none of them could give breastfeeding exclusively at 6 months and beyond. Maybe if we do this in Cambodia and other countries, maybe we can evaluate the effects of exclusive breastfeeding. In conclusion, prolonged full breastfeeding could reduce dental caries, but prolonged any breastfeeding could increase the risk of dental caries. Now, I will talk about breastfeeding and malocclusion. Actually, the mechanism between breastfeeding and malocclusion is well established. Breastfeeding is one of the cornerstones of a correct maxillofacial growth because it could promote lip seal, mandibular function, and tongue correct position against the palate. And when the children squeeze the milk out of their mother's breast, they have to force a synergistic action of both tongue and facial muscles. Whereas when the children do bottle feeding, they use less effort to drain the milk and thus understimulating the functional matrix. The effects of breastfeeding on malocclusion is summarized in several systematic review and meta-analysis, and I'll show you the most recent ones. In this meta-analysis, it includes also a few cohort studies in there, but most studies are cross-sectional studies, and they conclude that breastfeeding for over 6 months could reduce the risk for posterior crossbite, class 2 malocclusion, and non-space dentition. Other study, which is just published this year, also a systematic review of literature, basically show the same results. It concludes that breastfeeding is a protective factor against posterior crossbite and class 2 malocclusion. But for this study, they also show the effects on mixed dentition as well. So this is previously and in the previous paper, they show the effects only among primary dentition. However, the study could not find a clear evidence between breastfeeding and other type of malocclusion, including open bite or deep bite. But our study in Khon Kaen, we haven't published yet, but we have a data from the prospective cohort study that I mentioned earlier, the birth cohort study. We have data on overbite and overjet. And in that study, we could find the association between exclusive breastfeeding at beyond 6 months and reduced risk for overbite and overjet. So we still need to do a proper analysis to control for confounding, and maybe we could publish it soon. And these studies need more prospective longitudinal studies are needed. So there are actually not many longitudinal studies on malocclusion, but most studies show very similar results. The evidence is consistent. This is different from the evidence from dental caries. So in conclusion, the current evidence supports a protective effects of breastfeeding on primary dentition malocclusion, but less evidence is available for the mixed and permanent dentitions. Next, breastfeeding duration longer than 12 months increases carie risk, as does high frequency. Recommendation to reduce frequent and nocturnal breastfeeding from the second year of life may reduce carie risk without eroding beneficial breastfeeding. Recommendation for patients and dentists. Actually, I would give recommendation only for dental caries because malocclusion is actually protective and it's go along with the general recommendation for breastfeeding. For dental caries, although prolonged breastfeeding might increase the risk for dental caries, dentists should still support the evidence-based WHO guidelines with emphasis on the benefits for general health, because breastfeeding provide so many benefits on general health, and so we should still follow the guidelines. But then for those mothers who give their kids the long duration of breastfeeding, we should give them individual patient counseling. So when breastfeeding beyond 1 year, consultation with a dentist is necessary for the women, for examination and for prevention advice. Again, regarding dietary practice, especially on sugar intake and oral hygiene and supplemental fluoride. So I will end my talk here and would like to give acknowledgement to my colleagues, my research team, and the support from Thailand Research Fund and NIH. Thank you very much.
Thank you very much, Professor Waranuch, for the very interesting lecture. So we hope that our participants can benefit from the talk that I've given. Tonight we also have our Vice President, Professor Assoc Malik, who has joined us. I don't know whether you want to ask anything. I see that from the chat, there is no questions from the chat, and somebody raised his hand. I'm not sure whether he wants to by mistake or not, but I will try to allow him to speak. If he wants to ask you personally,
Datu, may I ask?
Okay, go ahead, Professor Shamali.
The excellent presentation. Actually, it is a so interesting topic that what she has chosen and so nicely presented.
Thank you.
I know that these topics are very rare topics, and generally people are not aware of it. And she so nicely explained it every step, and so nicely. I can just appreciate her, and this really, I love that I can have a positive comment that it is an excellent presentation. Thank you.
Thank you very much.
Thank you very much, Professor Assoc Malik. If may I ask, this breast milk that you give to the participants, Professor Waranuch, is this pure breast milk or any mix or what?
So actually, when we use the term full breast milk, that is pure breast milk, and any breast milk, any breastfeeding should be a mix of, like, it could be with or without formula milk. So, and this is observational study, so we actually do not provide anything to the patients, but then we ask them whether, like, how they give milk to their children. So we ask them every 6 months and update, so the mothers could say, like, very accurately when they stop giving breast milk to the children.
Okay, and we have one question from the Q&A from Professor Kalem. He asked, in your study, why did you not have a group who only needs bottle fed, i.e. no breastfeeding at all?
So actually we do have that group, but the results come out so mixed. So we decided to use the definition of full and any breastfeeding, and several papers in pediatrics also use the same definition. And so in the two studies that we use the same definition consistently. We also have other analysis of bottle feeding as well. I can show you later on, Professor Kalam, if you are interested. But the result is not so clear in that.
Okay, and another question from Professor Kalam is, do you think studies should separate out those moms who breastfeed only during the day and those who breastfeed all night, especially after 1 or 2 years of age?
Yes, actually, we have another variable. Like we also collect the data on nocturnal breastfeeding and found the association as well. Yes, and that's a very good question. Actually, nocturnal feeding is very important. And I think in the study, you also control for nocturnal breastfeeding and still see the effects.
Another question from Prof. Khon. The asked question is, do you consider mother who breastfed and bottle fed with breastfeeding only as full BF?
Full BF is only with only breast milk without bottle milk. Oh, you mean bottle fed with breast milk? Okay, yes, we do.
Okay, all right.
We do consider bottle fed with breast milk only as full breastfeeding. Yes, thank you for the question. Yes, I was confused at the beginning, but yes.
Okay.
So in the study, I'm sorry, because this is not related to malocclusion. So we considered this bottle fed with breast milk as full breastfeeding, because we do not care about the how to say, the lips movement and the force of the facial muscles. So if we study malocclusion, we have to separate breastfeeding and bottle feeding because of the different motions. But here, this is for caries. So we just use the normal definition of full breastfeeding.
Okay, thank you. There's another 2 questions for Waranuch. The first one is, if the caries protective elements in HBM decline over time, then why the caries prevalence for patients above 18 months in the study is lower than the shorter duration of breastfeeding? You get the question?
Yes, the protective effect decline over time.
Yeah.
By the caries prevalence. Yes. So it's quite a mix. Actually, you're very good to get this. Yes. So the effects of human breast milk, it's, as I mentioned, it's the mix of mechanism of protective and the negative effects. So it's very hard to tell. So when we discuss, it's also like we cannot really know what would be the real thing, because it's a mix between things. Yes. So I don't really know, actually. Yeah, but it's a good catch.
Okay, another question we have from Dr. T.C. Phua. Actually, our Dr. T.C. Phua is our region from Singapore. He asked, does your studies in Thailand show the trend or incidence of breastfeeding to be increasing or decreasing in modern days, mother?
Decreasing, yes, the incidence of breastfeeding decreases in Thailand. Yes. Yeah, and yeah, it's very hard to find mothers who give breast milk after 6 months of age, according to WHO recommendation. Actually, it's the data in the country is like 37%, but then like in our study, we could not find one. So I don't really know. Maybe it's an urban area.
Okay, all right. And then another question from Caleb again. Since there have been a lot of studies done already, where do you think future research related to early feeding practices should go? There are still unanswered questions.
Actually, it's yeah. Although there are many studies done, but then most studies are not cohort study, and even in our study we could not, because the number of children who have prolonged breastfeeding more than 18 months, it's very small number in our study. So even though we see the results, but then it's not significant. It's not really significant due to small sample size. So it's still, I would say it's still could not confirm from our study, and from many studies. Maybe we need to do a pool data of birth cohort study. And actually there's an initiation support by the Boro Foundation with Dr. Karen Perez in Singapore. Right now they are trying to do the meta-analysis using pool data of birth cohort study to evaluate the effects of breastfeeding and dental caries and other oral health outcomes as well. So these still, like, there's a lot of to do.
Thank you. There's one question in the chat box for Waranuch. He has a very excellent presentation. I would like to ask a question: what is the best period of time or advice to every mother or children care to take caretaker to feed their children in order to reduce ECC issues?
Oh, actually, it should be the combination. It's not only breast milk, but then the methods of feeding, of course, like nocturnal feeding, the feeding that the child sleep while they do feed, while they fed, and that's really the topic of concern. So when we analyze the results, we have to control for those factors as well: nocturnal breastfeeding and also sugar consumptions and other things. Yes, but I'm sure it's a combination. But then when we look at the separate effects, we can still see the effects of breast milk. So it may be we cannot measure the retention of the milk in the mouth. So it's hard to tell.
Okay, another question from Nipopon. In terms of caries risk, is it only composition of breast milk or combined with method of feeding, i.e. prolonged milk in the mouth in bottle feeding?
I think I already addressed this one.
So
composition of breast milk. Yes.
Okay, and then another question from Dr. Pithiphat. Are there any recommendation for mothers breastfeeding with vaccination for COVID-19?
Wow, very interesting questions. Actually, I don't know. I don't really know. So maybe someone in the audience could help to answer these questions, and perhaps those with small child who have experienced this themselves.
Actually,
Yes.
I can help her that COVID-19 do have these socio-economic effect and especially psychological effect rather to the feeding mother and to the society as well. So it has the impact, whether it is not so reported or not so nicely studied, but it must have an effect.
Okay, thank you, Professor Malik, for responding to the questions. I think that's all we get the questions from our participants tonight. Again, on behalf of Section 15, we'd like to thank you, Professor Waranuch, for sharing his experience with us. And we hope the lecture just now has been very fruitful and informative to our participants tonight. Okay, and then as usual, in 2 weeks' time, we would like to share our next speaker. Our next speaker is Professor Dr. Sunil Mudaya. He's from the Dean of Cook Dental Institute. So he will share with us on the topic Teledentistry, concept of artificial intelligence, functional and fixed appliance in orthodontics. So that will be our next topic webinar on 25th of May at 9:30 usual time, Malaysian time. Again, I hope you all can join us. And again, thank you very much, Professor Waranuch, for being here with us. And good night. And thank you, Professor Assoc, for joining, and also our region from Singapore, Dr. Pithiphat, for the questions, and also all the questions we have to look at. And thank you very much, and hope to see you all in our next webinar. Thank you, and good night.
Thank you.
Yeah. Bye and good night.
Bye.
Thank you, Amy and Datin.
Thank you, sir. Thank you very much.
Thank you.